We talk today is a little very basic, and it's actually, it's going to show a very basic principle where you can actually have clinical findings, and knowing the diseases leads to development of new agents that have actually made an impact on our treatment of prostate cancer. Again, is that we're going to talk about a little bit about what we call the disease state models in prostate cancer, since to get everybody up to speed here. What we really mean about castrate-resistant prostate cancer and some of the novel inhibitors that we have, inhibitors of androgen signaling, and some future directions where we're going. Just to start off, is this prostate cancer, this is the Tom's mantra here is personalized medicine, and this is where you can actually have a big impact on prostate cancer. And this just shows you the heterogeneity of the disease, and it's a very typical plot I show all my lectures. If you have prostate cancer starting here, and it can progress, and patients can have natural death here. Other patients can have a very quickly, rapidly progressing disease and die in a matter of months. The age range is hugely different. Youngest patient 35, 100, 105. So you talk about 7 decades. So there's a large amount of heterogeneity within prostate cancer itself. But what's important about prostate cancer is still a very logical order how it actually progresses. From local disease here, again, is that you can have surgery or radiation therapy. Subsequently, if you relapse there, you typically just have a biochemical marker and become what we call non-castrate rising PSA. That eventually this cancer can spread further to the bones or other structures. And when patients do have spreading of the cancer, typically we do castration or lowering of the male testosterone. And subsequently they become what we call castrate, rising PSA, or may have metastasis and be castrate. And typically it's once they have castrate metastatic disease, patients die from this. Just to review a little bit is that primary treatment for prostate cancer was actually described by Huggins. I mean, this was over 50 years ago. Again, is that we all shudder when we see these pathways sometimes from medical school, but the hypothalamus pituitary adrenal gland axis here, which actually secretes testosterone in the bloodstream and subsequently binds the androgen receptor and stimulates protein synthesis. Through the years, there have been different ways to actually get castration. Of course, the surgical orchiectomy, removal of the testicles here. But newer forms have been developed, what we call GnRH analogs, which actually bind to the hypothalamus and compete for the receptors here, and subsequently send signals down to actually, say, decrease testosterone. Then there's the other group here, what are called anti-androgens, which actually bind to the androgen receptor and block the androgen receptor, causing decrease in protein synthesis. But in very simple concept of development of androgen independence, or the end stage of prostate cancer, what we're talking about, again, is that these are mixed cells right here. Again, you go through androgen deprivation, testosterone low here, and subsequently you have cells that arise that are independent of androgens. And that's what we typically call, and in the literature, if you look out there, is of course, is that we try to change the name every 5 to 10 years just to confuse everybody. But it can be hormone-refractory prostate cancer, androgen-independent prostate cancer. The new term is what we call castrate-resistant prostate cancer. Once you actually relapse from primary hormonal therapy, there's multiple manipulations of hormones that you can actually do. Again, it's the one thing that we actually described almost 20 years ago is something called anti-androgen withdrawal syndrome, where you actually is when you're on an anti-androgen such as flutamide, bicalutamide, it actually works as an agonist over time and actually makes the cells grow. So by just withdrawing it, you can have a response that actually lasts 4 to 6 months and as palliative. Subsequently, if you haven't been on any of the anti-androgens, you can add those back and you could see response in 20 to 40% of the patients. Again, other classes such as Ketoconazole, which is an antifungal we typically use, we know it inhibits the P450 system and actually decreases steroidogenesis. Again, it can be effective also in 20% of the patients. But I think that, this is a startling fact that we actually, Dr. Moeller from up at Roswell Park actually showed, is on the left-hand side of the slide here is a patient with benign prostatic hypertrophy. On the right-hand side is a patient who had enlarged prostate cancer in there, was on hormonal therapy, and subsequently had a biopsy or a TERP done from this. And what they're staining here is for the androgen receptor. And what you see is that in the patients that were castrate resistant, there's an increased expression of the androgen receptor here, which suggests that testosterone, dihydrotestosterone occur in recurrent prostate cancer at sufficient levels to activate the androgen receptor. So what that means is even though we have somebody who has castrate levels, is the androgen receptor still playing a pivotal role in progression of even the most resistant prostate cancer. Another way to look at this, and this is really, it tells you a little bit about, cancer. And I think this is very important. As cancer goes through the natural treatment history, there's an evolution of cancer. And this is just looking at the androgen receptor from a primary tumor through it goes to castrate resistant. You can actually see the changes that occur in the androgen receptor throughout. So that as the time goes on, the tumor is changing, adapting to the environment. So what are some of the causes for resistant disease? Again, it's that you can have a hypersensitivity state where you can amplified androgen receptor. You can have a promiscuous state here where you actually, it actually binds to the pernicious androgen receptor, things like flutamide, like we talked about with the androgen withdrawal. Or can there be outlaw pathways such as EGF, which can actually stimulate the androgen receptor and cause cell growth. Then there's also other mechanisms that can bypass the androgen receptor. But these are the majority, people think that the majority of the progression, even in the late stage of disease when patients die from, are from patients still through the androgen receptor. So these findings right here are actually very important because this actually then targeted a lot of drug research in trying to understand androgens and further developing new drugs targeting androgens. And this drug is called Abiraterone acetate. It's a CYP17, it inhibits CYP17, it's the key androgenic steroid synthesis, and it actually targets 17-alpha hydrolysase and 17-20 lysase, and is able to very potently inhibit testosterone in multiple organs. Again, is that this is a little confusing, but again, is that this is the pathway here. Again, is that if you look right here, it actually inhibits the androgen precursors here, which actually decrease the testosterone. However, in patients, there's a reciprocal rebound here, so if you actually block these two, so what you get is a decrease in cortisol, and what happens, ACTH actually goes up, and subsequently, the side effects you get there is hypokalemia, hypertension, fluid over, and suppression of renin here. Again, it said, look at these, how quickly these can go up and the percentage of the rise can happen. But very simply and very eloquently was shown by these investigators is that after looking at these patients, they could just simply inhibit this by just giving back steroids. By giving back steroids, they decrease ACTH, and again, is that you can have a decrease in testosterone. So by very simply understanding the pathophysiology and the end targets, they were able to make a drug that was actually fairly not tolerable to a very tolerable drug. Well, how effective is it? This is what we call a waterfall plot, all right? Again, what is that? Again, is that one of the things that we use in prostate cancer is the serum marker PSA. And again, is that we look at the percentage decline of the PSA and plot it. And what this showed is in the initial phase 1 study, looked at patients who had a rising PSA or symptomatic from the prostate cancer, were given this drug. And you can see is the majority of patients actually had a response to this medication. But what's more interesting is in drugs that are precursors or similar to that, like ketoconazole, that also can inhibit steroidogenesis. This drug was much more potent and continued to have a response in these patients. Again, it's that there have been a series of phase 2 trials have done, again, overall small. But in the majority of the patients, anywhere from 50 to 70% of the patients, you are seeing patients' serum PSAs decline. Again, you see measurable disease regression in around half the patients. And again, it's that the majority of patients do have symptomatic relief from these medications. Tolerability, very good tolerability. Again, you can have peripheral edema, fatigue, nausea, and vomiting are the major toxicity we've seen, but again, they're actually very easily managed there. Again, is that these are now in phase 3 trials. I mean, in post-chemotherapy, we've seen responses after patients had multiple rounds of chemotherapy. These clinical trials have been done in the phase 3 setting, and it looks like they're actually very positive to date, and probably this drug will go on to FDA approval very shortly. Further trials looking at it early in the disease are ongoing. Well, another engineered drug was actually to target this, was a drug called MBD3100. This drug was engineered for activity in prostate cancer cells that overexpress the androgen receptor, is in the castrate-resistant disease. Binds to the AR more potently than other antiandrogens such as bicalutamide or flutamide. Unlike bicalutamide, which is another antiandrogen, the MBD3100 inhibits nuclear translocation of the androgen receptor, and it's binding to DNA. And it was able to induce apoptosis in prostate cancer cells, which most antiandrogens do not. Again, it doesn't show up very well here, but what it shows is that this is distinct from MBD3100 from other antiandrogens based on the androgen receptor binding affinity, nuclear transport, DNA binding, and coactivator status here. Again, as if you look in cell lines that are resistant to bicalutamide, you can actually see that this drug, even in the resistant cell lines with the MD31, showed decrease in cell growth, cell death, and no nuclearization within the nucleus. Again, initial studies, MDV3100 are ongoing. The phase 1 studies showed that it was actually very well tolerated. Fatigue, nausea, anorexia. Again, it says seizures were seen at the highest dose level up there. But again, it's at lower dose levels, below 250 milligrams per day. No seizure activity was seen. Similar drug from another drug company around the corner from here also looked at a similar drug to this. Actually, seizures was the dose-limiting toxicity and was pulled. So there is a possibility that seizures are a class action toxicity of this. Etiology of that's not really known. These are the waterfall plots in the initial phase 1 study of this. Again, is that in patients who've had no chemotherapy and those patients who've had chemotherapy, again, majority of patients who do see some clinical activity from the administration of the MDV3100. Overall, if you look at the response rates in this, is that 60 to 50% of the patients, depending on where, if they've had chemotherapy or no chemotherapy, partial responses, we're seeing around 30% of the patients. Again, is that the duration of these are actually quite long. I mean, some people are on these for 1 to 2 years, which typically, as we've seen, second-line therapies or even chemotherapy, typically we treat patients for around 6 months at the most. So even in the post-chemotherapy, these drugs seem to have activity with minimal toxicity. This is just an example of looking at some PET scans. Again, on the left here is an FDG PET scan. This is a fluorinated dihydrotestosterone scan here. Again, is that looking at a lymph node here. Again, is that just showing biological activity and the treatment of MDV 3100 and decrease in uptake noted there. So biologically active. Ongoing is their phase 3 trial called the Affirm trial. It's a phase 3 registration trial. It's going to, in patients who have failed primary chemotherapy, which is typically docetaxel in disease state, they're randomized to have MDV 3100 or placebo. Again, it's a survival trial over almost 1,200 patients there. Again, is that they're also going to be looking at see if there's any biological markers that we can actually look at to determine who can actually respond. You had Dr. Shashanian here from University of Michigan a few weeks ago talk about his TMPRSS2 ETS transcription and the fusion genes, which is important in prostate cancer. What we know is associated with poor risk prostate cancer. Again, is that studies have looked at circulating tumor cells in patients who have been treated with these anti-androgens. And what it does show is that there is some, when you have the ERG rearrangements, it was associated with magnitude of PSA declines with Abiraterone and MDV 3100. There's a concordance in the ERG gene status and castrate-resistant tumor biopsy. So if you biopsy the tumor and you look at the circulating cells, they actually paralleled each other. So, you know, right now, unlike breast cancer, we don't have a marker of sensitivity to hormone therapy. So we are looking at different ways to do it, and this may be very helpful. The one limiting factor is that you know, we only see circulating cells in around 40% of the patients who are chemo naive. It goes a little higher if you've had prior chemotherapy, so later on your more advanced disease, you see more circulating tumor cells. But in general, is that it can be a reasonable approach. So as we redefined castrate-resistant disease, again is that we're finding novel drugs here that actually, even if we think they're castrate, which is by the FDA standard, is the testosterone less than 50, is still we can come in with very potent inhibitors of androgen synthesis. And actually, we're developing a new disease state called androgen depleted. And these are being driven by alternative pathways. And these pathways can be co-regulators or a crosstalk transactivation. And our next efforts will be able to try to target these pathways along with the novel anti-androgens. Again, this doesn't show up well, but this actually shows all the different targets that are looking at in the castrate-resistant prostate cancer. And again, it's multiple new agents that are in prostate cancer. There's a lot of hope that we can actually develop new agents for prostate cancer over the next year, and you'll see some of those come to the market very soon. All right, I'll just stop there, and thank you for your attention.
One question to start with, Kevin. How good is a surrogate marker is PSA?
Yeah.
Does it correlate with survival? Does it correlate with symptoms?
We know that, you know, it depends if you look at, depends on what disease state you actually look at it in. I think, you know, you can actually correlate PSA to if you have recurrence after surgery. It's actually been shown to be a pretty good surrogate marker for relapse for patients who've had radiation therapy. Now, for the end disease, when we talk about castrate-resistant prostate cancer, it does not, it's not a surrogate marker. It is a marker of clinical activity, and it doesn't parallel to all patients. Patients with poorly differentiated cancers secrete very little PSA. A well-differentiated cancer can secrete a lot of PSA.
So if the MDV 3100 has some pro-apoptotic activity that's novel, what about combining that with cytotoxic agents?
Yeah, I think the development pathway is going down there, but you know, right now is they need to get it registered first.
In recent years, there's been movement in the chemotherapy sphere with prostate cancer,
They will be done. I mean, I think they'll be moving up there. Again, as that we just heard out in San Francisco, another very active agent called carboxytaxol that is improving survival. So there are multiple new agents. Again, as I think that most people will start, while they're going to be approved in the post-chemotherapy slot there, is they're relatively non-toxic and be moved up into pre-chemotherapy. Because it seems like it was actually very impressive, even those patients who are refractory to chemotherapy, is that these drugs have activity.
So, Kevin, since this is Yale and since Dr. Biopsy is standing over there, can you make a comment about the role of the Dendron vaccine in androgen-resistant or castrate-resistant prostate cancer?
Of course I can. Again, is that what we can say is that this is a dendritic-based vaccine against different epitopes of the prostate cancer cell. And again, is that they've done 3 trials, and all 3 trials have been positive for survival. However, is that if you look at clinical activity, typically, like if you look at PSA reduction, you look at measured disease regression or progression-free survival, those are not changed compared to the placebo. However, they had an update this weekend at GU ASCO, which actually confirmed further survival advantage of the Dendron compared to placebo. So it is going to committee.
Great. And one comment we say is going to committee is that Dr. Kelly is actually on the Oncology Drugs Advisory Committee for the FDA. So he sees all these products when they come to. Further questions? Yes?
Is there an association between androgen receptor levels and the likelihood of sensitivity to castration?
No, I mean, we've looked at that before, and there's not. Yep.
What's the future for like MRD detection before CRPC sets in? Circulating tumor cells, is it something that, what's the
Well, we know that circulating tumor cells, like in breast cancer and other malignancies, is the number actually correlates to overall prognosis. So it's a prognostic indicator. What we know is that it can be a predictor indicator of survival because if it decreases from the number of 5 to less than 5, will actually predict response to therapy. What we want to know is to get more of a molecular basis and then see if we can actually subselect treatments based on circulating cells. The problem is that with prostate cancer, as many of you may or may not know, is bone disease. And it's very hard to get tissue in that state. So we're looking at other ways that we can actually get tissue at the appropriate time in disease state. As you can see, as the continuum goes on, things change. So the primary biopsy doesn't parallel what we actually see at the end. So we need to be able to get to hold of tissue.
Is it still not possible to tell at the very beginning from the pathologist's point of view which tumors are going to be lethal?
Oh, we have 2 pathologists right here. They can answer that. Internal question. Send him to him. All right. I think that there's a lot of work looking at that, but I think it's a combination of things. Looking at I think what's more important is looking at the biological history of what's happened to the tumor, looking at the PSA history of a patient, looking at the primary Gleason or pathology, and also family history, because I think there is environmental factors and family history that actually play a role.
Dr. Mann?
A couple years ago, a rectovirus was reported. Can you bring us up to date about that?
Yeah, I mean, that's Eric Klein's and the Cleveland Clinic's data. They've looked at it. Again, is that they've done large studies, and the last update I heard is it was still in a small percentage of the prostate samples they isolated. So it's not the major driver at this time.
Peter may have already asked it, I didn't quite hear the answer. It seems like the cells after a period of energy deprivation are, I think what you'd expect, revving up their androgen receptor, trying to capture anything that's out there. If in that state, what happens if you just pulse them with androgen, they all go into a mitotic frenzy and then hit them with a mitotic agent?
We've actually done that study. It doesn't work. So, Yeah, he was. We have done that. The problem is that we don't have potent enough chemotherapies to really do that. I think that perhaps doing it with other cytotoxics that are more potent that we discover in the future may help.
Kevin, thanks for a fantastic talk.
Thanks.